This is in a series of videos produced by the Caribbean and African Health Network addressing the issues surrounding the COVID-19 pandemic and its impact on our communities.
Hi, Charles. Hello.
Hi, Dorota.
Who's speaking first? Yeah, can you hear me clearly?
Yeah, we can hear you.
Oh, God. So, is somebody speaking first, or?
No, you making a start.
Oh, I'll make the start.
Yeah.
Okay, so we have 8 people on so far. Okay, good morning, everybody. I hope you can see me. Hi. Yeah, my name's Doretta. I'm a fitness instructor. I deliver aerobic sessions, conditioning sessions, and spin classes, and also an athletics coach. The session I'm delivering today is to support your physical activity needs through the current crisis of COVID-19 and beyond. Yeah, we've got to be exercising and being active all the time. What is physical activity? Physical activity is moving, anything from cleaning the house, sweeping, going shopping, carrying heavy bags. Yeah, just moving around, playing with the children, having fun, playing chase. We also need to keep the mind active as well. So games like puzzles, crosswords, jigsaws, you know, I Spy games with the children. The most important thing is about having fun as well, keeping active and enjoying your lifestyle. Yet why do we need it? Because regular activity benefits the mind and the body. It helps to reduce high blood pressure, manage weight loss, reduce the risk of heart disease, stroke, and type 2 diabetes, and some cancers. It improves bone muscle and strength, balance, flexibility, mobility, and the release of synovial fluid around the joints, the shoulder joints, the knee joints, the hips, and keep them oiled and movable so that we can be more active. It also improves our mental health and can reduce the risk of depression, anxiety, cognitive decline, and delay the onset of dementia. So it releases serotonin, the endorphins, to help with the central nervous system to regulate the body's temperature, which is the body's thermostat. So we need to make sure that we're active because we release those hormones that we release help to ease the pressure in the mind, helps to reduce depression and anxiety. So all that kind of movement and everything else. All ages benefit from exercising. Everybody's supposed to exercise, even children under the age of 180 minutes a day. So any kind of movement we do with them, from pulling their arm, just lifting them, moving their legs, keeping them active. Keeping them active and doing little things with them as well. Infants under 5 years of age are also expected to exercise and do, well, not exercise, but move around, activity all the time. Adolescents 5 to 17 years, 60 minutes a day of moderate to vigorous exercises. So that can be walking, running, skipping, cycling. Adults 18 plus, 150 minutes a day, which is 3 to 5 times a week. Yeah, so 30 minutes a day. And you can break down your 30 minutes a day into 10 minutes, guys. You don't have to do the full 30 minutes. You can do 10 minutes in the morning, 10 minutes at lunch, and 10 minutes in the evening. That's your 30 minutes. But try to keep active. Older adults with poor mobility should do physical enhanced activities that will help them to enhance their balance, their mobility, in order to prevent them from falling, and causing injury to themselves. So we try to encourage our older participants to even do chair exercises, any kind of movement, and to use things like resistance bands. These resistance bands are very, very good for the elderly and those that can't move around, even for yourselves as well, if you can't use weights. There's things like dumbbells, there's weights like these, there's your dumbbells that you can use as well, or you can have no weights at all. It's about the actual movement. Yep, so we're going to start today's session. First of all, we're going to start with some breathing. So I'd like you all to stand or sit, put your hand on your tummy. You're going to breathe in through the nose. And as you breathe in, your tummy will expand, the chest will expand. So breathe in through the nose, hold it, 1, 2. Then as you breathe out through pursed lips, the tummy will go flat. Again, breathe in. and breathe out. Breathe in through the nostrils. Big deep breath, hold, tummy's nice and big, expand the rib cage and slowly breathe out. And again, breathe in. Tummy goes big. Hold 2 and breathe out. Now we're going to take the hands out in front of us and we're going to do the same thing again. Breathe in, take the arms out and breathe out. Breathe in, breathe out. Last one, breathe in. Breathe out. Okay, let's roll those shoulders back. 5 rolls back. 1, 2, 3, 4, 5. 5 rolls forward. 1, 2, 3, 4, 5. Take the arms up and take it right back. Big arm circles. 5. Take it round. Back. 1, 2, 3, 4, 5. And forward. 1, 2. Take them round. 3, 4, 5. Remember, you can do these exercises sitting as well, guys. We're going to take the knees up to the elbows. Opposite arm, opposite leg. Remember, if you're sitting, you can still do it sitting. So sit down in the chair, and all you do is just lift the knees up to the elbows, standing tall or sitting. Lift it up, opposite side. Good. Really take it right round, working the sides and the obliques and the hips. Good. Next exercise is skipping. So with a skipping rope, with or without a skipping rope, you're just going to turn your hands and jump and mimic the skipping. Keep the elbows close into the side and just turn the hand and jump. Those of you that are sitting, just lift both feet. I hope you can see me sitting. Let me just adjust this camera. So as you're sitting in the chair, you're just going to lift your feet. Lift, lift, hold the side of the chair and lift your feet. That's your skipping. And just lift it up. Good. 9, 10, and stop. Stand tall, shake the shoulders out. Shake it out, guys. Well done. Hope you can see me today. We're going to work on the upper body. 2 exercises for the top, 2 exercises for the lower body, and then we'll work the abs. So 5 exercises all together. First exercise. With dumbbells or with a bottle of water or no weights at all, or you can have a flat weight. Yep.
In April,
Yeah, boy.
We're going to take the hands out to the side.
I had chemotherapy, radiotherapy.
Yeah.
The side like so. Lateral raises. Curl them in. Take it out. Drop it down. So hands by the side. We're doing 10. Are we ready? Even seated, you can still do the same exercises. Hands down by the side and lift and curl. Here we go. 1, curl, out, drop. 2, curl, out, drop. 3, curl, out, drop. 4, curl, out, drop. 5, curl, out, drop. 6, curl, out, drop. 7, curl, out, drop. 8, curl, out, drop. 9, curl, out, drop. 10, curl, out, drop. Notice I use a bottle and I use the flat weights as well as you can use dumbbells. Second exercise is shoulder press. I'm going to use the dumbbells. We're going to keep the elbows at shoulder height. Even if you're sitting, you can still do this exercise sitting. Keep the elbows up, palms face the front. Let's push and tap to the top, down. 1, 2. If you can't do both arms, do 1. Push. Go. 2. Come on. 3, sorry. 4. 5. 6. 7. 8. 9. Last one. 10. Take it down. Shake those arms out. Shake it out. Next exercise is heel raises. Well, you can see me, guys. If you need to use a chair, feel free to hold on, push up and drop. Push up and drop. We're doing 20 of those. If you can do it with a weight, hands up. Push up from the toes, onto the toes, from the heels up. Push up. 1, drop. 2, squeeze as well. Pull in. 3, 4, pull. 5, push up. 6, push up. 7, push up. 8, the chair. 9, lift those heels. 10, lift those heels. 10 more. 9 more. Pull it in. Squeeze. 11, 12, 13, sitting. Just stay seating and lift your heels. 15, push. 16, push. 16,
My workout is the
lift.
best.
17, lift. 18, lift. 19, lift. 20, lift. And relax, guys. Second exercise is lunges. So we're here. Keep your legs nice and wide. Imagine somebody's pushing you down from the head. So it's drop, push up, drop, push up, drop, push up. If you need to use the chair, hold on to the side, support, and drop down and push up. Are we ready? Off we go. Stride out that leg. Lift the heel, the back heel, and come down. 1, push up tall. 2, push up tall. 3, 4, 5, 6, push up. 7, 8, 9, good. 10. If you need to use some weights, you can do. Change legs. So you'll be here. Bicep curl as you come down. Off we go. 1, push up. 2, push up. 3, push it up. 4, good. 5, 6, 7, 8, 9, 10. Well done, guys. Shake those legs out. Shake it out. Next exercise is the twist, push, twist, push. Known as a Russian twist. You can do this sitting on the floor, standing, or sitting on a chair. I'll show you the chair with a weight. Here we go. Sit halfway on the chair, on the thighs, tap to the side, push, tap to the side, push, tap to the side, push. Standing, twist, push, twist, push. Tap the side of the hips, push, tap the side, push, tap the side, push. Here we go. Ready to go? 20, 10 on each side. Here we go. Tap, push, 2, push, 3, push, 4, push, 5, push, 6, push, 7, push, 8, push, 9, push, 10, push, 10 more, 11, push, 12, push, come on, 14, push, 6 more, 6, push, 5, push, 4, push, 3, push, 2, push, 1, push. Good, march it out, guys. March it out. Good, well done. Keep it going. Let's march it out. March it out. Okay, next exercise is squats. Last exercise with the chair. Come down, hold the chair at the side and push up. Squat down into the chair and push up. If you don't need the chair, hold your hand like so. Elbows will touch the thighs. Come down and push up. We're doing 10 of those, guys. Are we ready? Okay, with or without the chair. You can hold a weight, put your hands out in front. 1, squeeze the hips forward. 2, squeeze the hips forward. 3, squeeze it forward. 5, squeeze it forward. 6, squeeze it forward. 7, squeeze it forward. 8, squeeze it forward. 9, squeeze it forward. Last one. 10, squeeze it forward. Well done, guys. Bear with me there. Okay. 6 exercises there, guys. You can do this set 3 times. You don't have to do it 10. You can do 20. You can use weights, whichever one you want to use. But now we're going to just go for a cool down of stretches.
Winner. Now let's play bingo Paddy Power style. How about
Skip that. There we go. Okay. Roll the shoulders back for the cool down. Roll it back. Even sitting in the chair, just roll it back. It's a nice sunny day, guys. Get the body ready, active, and forward. Roll it forward, standing or sitting. Roll it forward, lift and take it forward. Reach the hand up and then drop to the side. Hold on to the chair if you're in the chair and drop to the side. If you're standing, just reach down, past your knee, touching the calf. Hold that stretch. Turn the chest towards the sky, towards the ceiling. Hold it there. Feel the stretch. And to the other side. Reach right down. Twist the chest towards the ceiling and feel the stretch. Sitting in the chair, same thing. Hold the side and just take it over. Good. Big arm circles. 2. Going back. 3. Seated. You can still do it seated. You can do one hand if you want to do one hand, guys. Take it right back. Push it right back. And forward. Here we go. Take it forward. Get those arms coming past the ears. Right by the ears. Nice and tall. Lifting the rib cage. Working the diaphragm. Controlling the breathing. Good. Now let's just twist from side to side. Twist, 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 twist. Sitting on the chair. Twist and touch the side of the chair. Twist, twist, touch the side of the chair. Twist, 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 twist. Lift the arms up on the chair. Fall forward. Rest your chest and your head on your thighs. If you're standing, stand tall, fall forward, and just hold here. And really push the back and stretch out. Good, so that's standing. Remember sitting, you fall like so, and stretch out those hands in front of the toes. Take it back up, arms out, big hug to the self, big hug, guys. And well done. Thank you very much, guys. Thank you. I hope you enjoyed that 20-minute workout and it did something for you. Well done. Okay. And thank you, Charles.
Okay.
You don't have to do these exercises just 10 times. You can do them 3 sets of 10, 3 sets of 20. You can use weights, you know, add things to it that you can use for yourself, that you can manage as well. Remember, you can do them seated, you can do them standing, you can do them lying down. You know, if anybody wants to contact me separately, that's fine to do that as well. So please do. Yeah, we only have 30 minutes on a Saturday morning now. So that 30 minutes, we have to try and get as much in as we can. So the exercises that I've done for you today, normally you do 3 sets of 10, 3 sets of 20, use weights, as I've said before, use your resistance bands as well. So well done, guys. And thank you all very much for joining.
Dorota, you have another 10 minutes.
Oh, we got 10 minutes?
Yeah.
Oh, wow. I thought I'd gone over. Well, if we've got 10 minutes, guys, let's do that same set again, if you don't mind. We'll go through it again. Hooray, that's good.
Councils across the UK are abandoning families, leaving them to pay enormous fees when a loved.
Okay. Start with the lateral raises. We're all still warmed up. Here we go, straight through, non-stop. Arms by the side. Nice and long, seated. Remember, you can do it seated. And off we go. Lift, curl, out, drop. Lift, curl, out, drop. 3, curl, out, drop. 4, curl, out, drop. 5, curl, out, drop. 6, curl, out, drop. Come on. 7, curl, out, drop. 8, curl, out, drop. 9, curl, out, drop. 10, curl, out, drop. Shake it out, guys. Here we go for the shoulder press. 10 shoulder press. Take those arms here. Remember, you can do it seated like we did before. Palms facing forward, elbow shoulder height. 10 pushes like so. Watch first. Tap, bring it back. Tap, bring it back. Here we go. 10. 1, 2, 3, 4, 5, 6, 7, 8. Pull those abs in. 9, 10. Relax. Shake it out. Here we go with the lunges. Hope you can see my lunges. Let me just adjust this camera again. Good. Take the leg out. Over here. Remember, you can use the chair. One leg back, lift that heel, and drop. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Keep the balance, change legs, shake it out, take the leg back, lift that back heel, keep the hips nice and strong, and drop down. 1, push, 2, push, 3, push, 4. I'm using weights this time. 7, 8, 9, 10. Push up tall, shake it out. Next exercise is the squats. So remember, you can use the chair. We're going to stay here and squat down like so and squeeze. Off we go. 10. 1. Squeeze it. 3. Squeeze. 4. Squeeze. 5. Squeeze. Keep the hamstring to the ground. 6. Squeeze. 7. Squeeze. 8. Squeeze. 9. Squeeze. 10. Squeeze. Shake it out. Helps to strengthen the knees. Exercise is good for you. Okay, Russian twist, standing. Twist, stretch, twist, stretch. Yep. Or sitting. Twist, tap the chair, stretch, tap the chair, push. Are we ready? On both sides. Here we go. 20 all together. 1, push. 2, push. 3, push. 4, push. 5, push. 6, push. 7, push. 8, push. 9, push. 10, push. 11, push. 12, push. 13, push. 14, push. 15, push. Tap right round. 16, push. 17, push. 18, push. 19, push. 20, push. Woo! Shake it out. You can feel it in your shoulders as well, guys. Shake it out. Last exercise I'm going to introduce into this one before we finish. I think we've still got a few minutes. Yeah. 3 minutes. Come on, guys. 3 minutes. Take it up. And we're going to take the leg out to the side. Don't touch the floor in return. Don't leave. Let's work those hips. If you're seated, stretch the leg out and just move it out. And bring it back. Okay. Here we go. 10 on each side. Are we ready? Stretch up those arms. Pull it up. Work the torso. Lift that diaphragm. Control your breathing. 10 on each side. Off we go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Go to the side, shake those hips out, lift up that foot, and off we go. 1, 2, 3, 4, 5, 6, 7, 8, come on. 9, here we go. 10. Well done, guys. Shake it out. You should feel it in the hips. Working those hips, those stabilizers, getting them nice and strong. So I hope you've enjoyed that, guys. Hope you've enjoyed that. So we've had our workout for the morning. Can you all hear me?
Yes, we can. Thanks, Dorota.
Well done, guys.
Dorota.
You're very welcome.
So we will be seeing you again next week.
Yes, I will have some different exercises next week as well.
Yeah.
There'll be 5 or 6 exercises each week, so we can get them in and do the 3 sets if we can.
Sure. Thank you.
Thank you very much, guys.
Okay, right. So the second half of this, session, we're gonna have, a GP joining us all the way from Staffordshire. So I'm going to introduce Dr. Diana Asante. She's currently based in Staffordshire. She's a GP. She's been practicing for the last 15 years and has worked in various, towns, across the UK. Currently seeing patients on a day-to-day basis. And we're going to ask her to introduce herself, and then we will all give her a couple of questions to answer. So welcome, Diana, to the Caribbean and African Health Network. No, you're on mute. Good.
I think I've unmuted myself.
Yes, you have. No, sorry, it looks like you've muted yourself again.
Hello?
Yes, we can hear you now.
Right, okay. I'll start from the top because I'm not sure what you heard and what you didn't. So thank you for this, Anna. I'm really privileged to be a part of you today. Well done, Charles, to you and your team for all that you're doing. Yes, so as Charles said, I'm a GP. I finished medical school in 2005, so I've been a doctor since then, done different specialities in the hospitals, and then finally specialized in general practice, where I've been since 2014. So you want us to talk about coronavirus today, is that right?
Yes, indeed.
And I'm sure we are all inundated with information about coronavirus. But before I proceed, I want to say thank you to Doretta. That was really wonderful. Great job. I like your enthusiasm. Thumbs up to you, sis, for that. Keep it going. It definitely got us doing some workouts in our homes, which is what we need in these times. So because we hear literally so much about coronavirus on a daily basis, I'm not going to bore you. I think we've got a Q&A session, haven't we?
Yes, we
so
do.
we'll just be very brief, and then we'll move on to people asking questions so that we can be very specific and targeted in what's useful. All the stuff that you need to know, you probably know, because the daily briefings, that's all that we talk about these days. There's no other news apart from coronavirus, so everyone knows a lot about it. But just as a very quick recap, coronavirus itself is a family of viruses. So it's not just this one virus, it's a family of viruses, and the family is called coronaviruses. And this particular one that we're worried about at this point in time, COVID-19, is just one of the members of the coronavirus family. It's just one that we hadn't known much about before. So when it first broke out in Wuhan, in China in December 2019, it was called a novel coronavirus, which means a new coronavirus. And then later, when they realized that actually this is what it's doing, they gave it a name, which is called SARS-CoV-2. So if you want to write that down, Charles, or people know that already, it's SARS-CoV-2. That's the name of this particular coronavirus, where SARS means severe acute respiratory syndrome, and then the CoV is the coronavirus, and it's a 2 because there is a SARS-CoV already. There was a SARS-CoV already, which caused the SARS disease. So coronaviruses themselves are not a new thing to the world. We've known them for decades, but this particular one, which causes COVID-19, is what we're grappling with at the moment. So as we know, it spread very quickly from just a few cases in China to becoming a global pandemic, where at the moment we almost most countries in the world have it. It's a pandemic at this stage, which means it's pretty much everywhere. And generally at the moment, I think when I checked the figures as of yesterday, we've got about 3.3 million confirmed cases worldwide. So that is just the people who've been tested, who've been confirmed, and at least 235,000 deaths, confirmed deaths. So those who haven't had tests, those who are walking around who don't know they've got it, those who haven't been recorded, is not captured in this data. In the UK, most of us probably listen to the news, or probably we don't because we're getting bored and depressed of it. But we are around over 27,000 deaths at the moment. That figure is probably truly more than what it actually is on the ground. The common symptoms are like flu-like symptoms, and that's why people, when it first started, people thought, oh, this is just another kind of flu. But no, it isn't just another kind of flu. It's quite a severe illness, as we've come to realize, with quite a great impact on everything that we do. So the common things that people can get would be a cough, or a temperature, or shortness of breath, or a sore throat, or, cold flu-like symptoms, aches and pains here and there. The algorithm that 111 will go through, or the NHS is sort of using to class people as suspected COVID, are the three things: a temperature of more than 37.8 degrees, shortness of breath, and new onset continuous or persistent cough. But to be honest, it doesn't mean that if you've got another symptom apart from those three, you couldn't have coronavirus. So we all need to be careful. And equally, there are people who are pre-symptomatic. They may not be showing any symptoms yet. Or some people who indeed are asymptomatic. They never show any symptoms, but they test positive if they do happen to get a test. So that's just briefly about the symptoms. It's a range of symptoms, even including gastrointestinal symptoms like diarrhea, running tummy, all sorts can present. So basically, if you're not feeling well, speak to someone who knows what they're doing, who can give you some advice on it. Most of the advice is for us to be staying at home, washing our hands, adhering to the social distancing measures so that we reduce the transmission, using, alcohol gels or sanitizers or whatever, to keep our hands clean and to stop passing on the virus from people to people. Common things that can pass it on: someone coughing on you, or someone sneezing on you, or even talking within a short distance where droplets can be transmitted. It's basically a droplet infection. So I think there's this myth out there that it's in the air, and if you're walking around and you breathe it in, you could get coronavirus. But that is not the sort of mode of transmission per se. It's a droplet. So you need someone who's infected to cough on you, or to sneeze on you, or to talk to you within a reasonable distance where the droplets can then be transmitted. Or they probably sneeze on their hands, they touch a surface, you then go and touch that surface, and then you touch your mouth, or you rub your eyes with it, or you go and touch something else. Or they, sneezed on their hands, or they've picked their nose, or they've rubbed their eyes, and they hold the door handle, and then you go and hold the sort of same door handle, that kind of thing. So it's quite important, and that is why the preventative measures are probably the greatest asset that we've got in this whole war that we're fighting, this unseen enemy that we're fighting, is preventing yourself from catching it as much as possible. So the washing of the hands, the cleansing of the hands, the sanitizing of the hands, the making sure that you're catching it and you're binning it and you're washing your hands, getting the message through to the kids. I mean, try telling a 3 or 4 year old that they shouldn't hold the railings, or when you're going down the escalator, tell them not to hold the sides. Practically impossible. They're constantly picking their nose, they're rubbing their eyes, they're touching things. So it's just sort of encouraging those messages, reinforcing those messages over and over again. So we know that bit, and I'm sure most of us are doing it over and over again. And then the social distancing is quite important as well. Well, we're calling it physical distancing these days because we want to remain social. So I think the terminology is changing a little bit on that front, where people are sort of saying physical distancing because we're staying apart physically, but socially we still want to be connected like we're doing today. We're socially connecting. So the physical distancing of 2 meters is the recommended, and where it's not possible, doing everything you can to reinforce the other measures. So let's move on swiftly from there, the things that we can do to prevent it, and then go on to, if you do get symptoms, what do you do? Let's say you're there, we're here, and then you suddenly start having a cough. And it's not just an ordinary cough. It's a cough that, you're coughing persistently or constantly. It's typically a dry cough as well, worth mentioning. But the one thing we should know about coronavirus or SARS-CoV-2 is that it's still a very new virus, and we're learning on the job. And every single day we're getting new things come up. Like right at the beginning, there was this symptom of anosmia, loss of smell, that came up. And people weren't quite sure about it. But now we're realizing that it is quite a common symptom that some people can present. They may not have the cough or the temperature or anything else, but what they might just present with is a loss of smell. So going back to the point I was raising, is we say a dry persistent cough. It doesn't mean that if you've got a wet cough, it couldn't be. We're just saying that that's not the typical nature of it. So if there's any cough that you've got, obviously when you ring 111, they're going to tell you to start self-isolating for 7 days and then your household for 14 days. Or if you've got a temperature of 37.8 or a new shortness of breath. And those are the 3 things that they're going by to sort of give advice to people about self-isolating. For purposes of how do we sort of manage these symptoms, just a broad brush approach, because I'm sure when we start asking the questions, we'll have specifics. If your symptoms are such that you're well enough, I could be coughing, but I'm still fine to do my daily jobs. I'm still able to go up and down at home. I'm not struggling with my breathing to the point where I have to stop. I can't go up the stairs, or I can't even, do the simple things that I do. And I can control my temperature with simple paracetamol. Then I don't need to be in hospital. And to be honest, at this point, most people don't want to be in hospital because they've got this feeling that the hospital is currently probably not the safest place to be. So if your symptoms are mild that way, then you self-isolate, you stay at home. And then you manage it as you normally would, with fluids, with exercising, as Doretta has taught us. One thing we should know is that sitting still, being idle, being inactive is not helpful. You need to keep moving, you need to keep going as much as you possibly can to get your circulatory system working, to get your breathing improving, to get your body's sort of systems recruited to try and help in that recovery process. So no amount of exercise or physical mobility is too little. As much as you can and as little as you can would definitely be beneficial. So you're doing that, you're having your fluids, you're having your simple measures as well, and then you're exercising and you're keeping an eye on the symptoms. Another thing we know is that people can deteriorate suddenly, and it tends to be the deterioration comes with shortness of breath. So that's the one thing that tends to be what gets worse for most people. So probably you find that you're breathing okay, not too bad, and then suddenly people find breathing is becoming a real job here. I'm actually struggling with this. And that is a good point to speak to somebody to say, look, this is the situation. What do I do? Because if it's appropriate, they might be able to arrange for you to be seen in a hot clinic if you've got other symptoms they're concerned about, to have your SATs checked, for instance, or have a listen to your chest. So that is quite useful. Obviously, if your breathing is deteriorated to the point where you're really struggling, then obviously you need emergency treatment for that. And probably the people who end up at the end of the spectrum where they then go into respiratory distress, they're the ones who are going to end up in hospital and need high flow oxygen, CPAP, ventilation, etc., depending on how bad they get. So that is sort of in terms of the management. If you're well enough to stay at home, then do that, manage simple symptoms. If you notice that your symptoms haven't gotten better after 7 days, you must consult your GP via the phone. We're asking people not to come to the surgery. Please don't just tip up. Most things are done over the phone these days. We'll triage you, and if you need to come in, we'll let you know, offer you an appointment in a safe way. Safe for the patient, safe for the rest of the population, and safe for the staff. And obviously, if you need to go into hospital, we can advise along those lines as well. If it's not during normal working hours, then you'll be ringing 111. Or you can just go on the NHS 111 website and follow the algorithm, and it would give you advice. They were very inundated with calls. So if you were trying to ring 111, you might find you're not actually getting through. So if it's something that you need advice on, you can go onto the NHS 111 website and they ask you questions, you go through the flow and it tells you what the outcome is. But if you do need to speak to somebody and you can't speak to your GP because it's not in hours between 8 o'clock and 6:30, say it's after 6:30 p.m., then it's 111. If you can't get hold of them on the phone and it's an emergency, then obviously you're going to be going into hospital. And if via ambulance is what's appropriate, then that's what's appropriate. So I'll move swiftly on from there. Where are we at the moment? Is there any current treatment available? No, there's no proven treatment available. Obviously, there are all sorts of things being circulated out there, from mum's potions to traditional stuff to orthodox stuff to trials of different medications. We've heard all sorts of names, from hydroxychloroquine, which they trialed and there wasn't any evidence. And then we've heard people talking about antiplatelet medications because they think that there's some kind of phenomenon where a clotting process takes place and that can also affect people severely. Again, there isn't strong evidence on that. We've heard stuff about vitamin D, which we'll be talking about a little bit later. We've heard stuff about new drugs as well. But just to briefly say that there isn't anything that is yet proven that has gone through the large-scale randomized controlled trials that we would normally subject these medications to be able to authorize them as safe for public use. So all the names that you might be hearing are things that are still undergoing trial or have been written off because they've not been successful or are still being looked into. The current one now is remdesivir, which is an antiviral that was used with Ebola. That's the one they're sort of looking at the moment. In the US, it showed that it sort of reduced the duration of the illness from about 15 days to 8 days. When the Chinese people did it, they said there was no reduction in the duration. The US people said no reduction in mortality. The Chinese people said there was no reduction in mortality. That's people dying. So we're not certain yet exactly on what the outcome will be. But if there's anything that's looking a bit promising, that's probably the one. But it's still early days yet. One more thing I was going to talk about in terms of treatment. Yeah, so we've mentioned those ones and we said that none of them is sort of confirmed yet. And then in terms of a vaccine trial, we all know that vaccine trials take decades, a very long process, takes a very long time. On this occasion, thank God, things seem to be moving at a very fast pace. And we know that Oxford University is working with AstraZeneca, which is a very well-known pharmaceutical company. And they are trying their best to come up with a vaccine. But truth be told, that's not something we can be banking our hopes on now. They are saying autumn, but that sounds like a very sort of over-enthusiastic estimation. So I think realistically, most scientists are saying we're looking at least 12 to 18 months. So either way, there's nothing that's sort of going to come up within the next few days. And if you can imagine the situation we are in now, we need something that we can hold on to that can sort of take us through now. We don't have 18 months to just sit for 18 months and wait. I don't think any of you has like just 18 months to just sit there and wait for another 18 months for something to happen. So we need to focus on the things that we can do now, the things that we've got control over now, like the social distancing, like the staying at home, the easing the pressure on the NHS, the staying safe. And when things begin to ease, the adhering to the measures that would help us really move into the second phase. The Prime Minister was talking about the fact that looking at the graph, we've probably gone past the peak, and everyone says that cautiously when we're saying we've gone past the peak, because we look at the graph and it looks like things have sort of begun to go down slowly. We're preparing for moving into the second phase of this, which is trying to restore things. So during the last few weeks, some of you would have realized or noticed that the usual stuff that you'd get done at your general practice doesn't happen. You don't go in for an appointment, you get a phone call, you're asked not to go there, you're told you'll be contacted. If you need to be referred to physio or to, ENT or something, it's probably not happening. We were only referring for rule out cancer cases. And even that, people themselves were trying not to put pressure on the NHS by not even sort of coming up with things that they really needed to come up and tell us about. So then we started saying, please tell us about your problems, because we are missing some cancer cases here that we need to be picking up. So hopefully over the next few weeks, as things begin to ease, doesn't mean we're going to go back to normal. We need to get used to the new normal. But as things begin to ease up a bit, we might find that some of these services are being reintroduced. But whatever shape or form this easing takes place in, there will still be that need for clear adherence to social distancing. There will still be the need for that strict hand washing, strict hand sanitizing, strict sort of protocols that we've had in place in the last few weeks to make sure we don't then have a resurgence of the peak happening, and probably a worse peak than we've had before. I feel like I've been talking for a very long time, although I probably haven't. So I'm going to leave it there for now. I've got information on different things, but I'm sure that as the questions sort of come up, we'll probably touch on those things. And if there's anything that we haven't touched on, sort of towards the last 5 minutes, I'll chip it in for us. So I hope that was a sort of hopefully brief enough introduction, Charles.
Yeah, well, I mean, yeah, lots of insight and in plain English. So we're really grateful, Dr. Asante. So a couple of questions that have been sent ahead of this session. Can you explain the workings of the immune system and what we as Black people can do to improve our immune system?
Right. So, I mean, immune system is a very broad sort of term. So basically, I'll try and make things as simple as possible. So I'll try and avoid the jargons as much as possible. Pardon me, sometimes it just slip out because that's how we're used to speaking, but I will try and simplify it, I promise. So immune system is basically your army, your whatever fights your infection. And we've all got a general immune system. So that's the general army. And if you can imagine that like, or rather your protective mechanism. But if you can imagine that with a protective mechanism or with a sort of protection of the nation, you might have the army, the navy, the air force sort of thing. So with our immune system, just to simply put it, we've got two main ways in which it functions. So you've got your natural immune system, which you have, is innate, is born with you, is in your genes, is what your gene predisposes you to certain things you can fight, certain things you can't, because of how your gene is made up. And then we've got the acquired one, which is when we're exposed to things, our body then develops soldiers or antibodies to these things. And so most of the things like the viruses, the bacteria, etc., that we come into contact with, it can trigger our acquired immune system to then sort of develop a way of fighting, so that next time you encounter the same enemy, hopefully you've developed some defenses. And then the natural one is where things like your race, your age, your genetic predisposition comes into play. So putting it in the context of BAME people, we have a great immune system. We're well set up to fight a lot of things. And our acquired immune system is also great as well, because we have come into contact with quite a lot of things in life. Specifically in terms of how the body will react to an antigen or an enemy or an inciting factor, in this case, for instance, coronavirus, it depends on a lot of factors. So it depends on how healthy the person is. It depends on how unhealthy the person is. So if you take someone who is healthy, they haven't got any disease whatsoever, they've not been diagnosed with anything, they're not on any medication, they're healthy, they exercise, and there's nothing wrong with them, then if you compare that person to, for instance, person B, who might have other illnesses like diabetes, like hypertension, like heart disease, like an irregular heart rhythm, for instance, then already you can see that the starting point for both of them is not the same. Because when you have something happen to your body, it's the same things that would fight infections are going to try and fight those infections. Already, some of these soldiers are fighting diabetes on a daily basis. Some of these soldiers are recruited to fight your hypertension. Some of them are recruited to fight your rheumatoid arthritis. So when you then get hit by something else, like a virus, you don't have enough ammunition to fight it, compared to someone who has their army intact, and when they're hit by a virus, they can, deal with those things. How do we improve our immune system? Exercise. I've seen that question pop up, so I'll just tackle it straight away. So exercise is useful. Eating healthily is useful. Black, Asian, and minority ethnic groups, we're probably not the greatest when it comes to our diet, just because of the nature of our diet. We have a lot of salt in our diet, we have a lot of spice, we like our flavors, and all those things can predispose us to cardiovascular disease as well. We may not be the greatest people when it comes to vegetables and fruits. It's probably not the things that we'd prefer to have. We'd rather have a piece of cake or something rather than have a fruit or a veg. So our diet can help us improve our immune system, and things that produce antioxidants, fruits produce antioxidants, vegetables produce antioxidants. So all of those things can improve our immune system. Medications to sort of improve your immune system is not really the best thing, because most of the medications that people will be taking is to fight something else. So we're talking about how can someone improve their own immune system by the simple things that they do. Now, let me bring in vitamin D here quickly, because vitamin D is a vitamin, and it sort of helps partly modulate our immune system, but it also helps in strengthening bones and teeth and all those things which we're aware of. Our body doesn't produce its own vitamin D. We tend to get most of it from the sunlight, and then we tend to get it from foods as well. So fish and eggs, dairy, stuff like that. But with the black skin, with the dark skin, because of the pigment melanin that we have, when we are exposed to the sunlight, we don't take as much vitamin D in compared to a lighter skinned person. So we still get the vitamin D from the sunlight, but we're not getting enough. So if I stand in the sun for, say, 20 minutes, and then a white-skinned person stands in the sun for 20 minutes, chances are that they're going to absorb more vitamin D in that time than I would. Flip the coin, they would probably also be more predisposed to skin cancers because they lack the melanin protection, whereas we might have a better protection because of the melanin. So it's a two-way thing. But that is about vitamin D, and vitamin D will boost the immune system. However, it hasn't been proven to prevent people getting coronavirus. And let's be very clear about this. It hasn't been proven to reduce the impact of people who have had coronavirus, simply because we haven't done those tests and we cannot say this is the case. We know that generally vitamin D can boost people's immune system, and it does improve how they react or how they would respond to respiratory illnesses like common cold and things like that. But because in this particular case, we haven't actually looked at a group of people and seen how their vitamin D levels has correlated with coronavirus in this instance, we cannot categorically say it does have an impact, but it's certainly not going to do anybody any harm taking vitamin D. Now, one thing I must say as well is before coronavirus came, we were recommending that every single person in the UK in the winter months has to be taking vitamin D supplements anyway. So this is pre-coronavirus era, because we don't get enough sunshine in the winter months. And so we were going to be lacking the vitamin D that we would normally get anyway. So it was recommendation by NICE, the National Institute of Clinical Excellence, that we should be taking vitamin D. Everybody should be taking vitamin D in the winter months, especially those people who are in risk groups like pregnant people, young children, elderly people, people who are constantly indoors and don't go out. But winter months is a no-brainer. We should all be taking it. And the minimum you need is 10 micrograms. They sell it over the counter, and it's just, I think it's about £1. I've got one in my cabinet. Give me 2 seconds. I'll grab it and show it to you. Right, sorry about that. So this is just to show you, yeah? All you need is vitamin D. This is even the high dose one, which has 1,000 international units, which is way more than we need. We only need 10 micrograms. But if you can get this, and guess how much this costs? This cost me £1, 2p. I bought this a long time ago. And then, interestingly enough, and Charles is probably going to laugh at this, I'd written it on the list of things for us to buy. So I wrote vitamin D. And when I bought it, I forgot to cross it off the list. So my husband went to town, and when he went, he bought vitamin D. He bought the same thing. Can you see the price on it? £5.10. Exactly the same thing. This is branding. So when you go, all you need is vitamin D, and it's the same thing. 1,000 international units. It's as cheap as £1. I gather at the moment they're off the shelves anyway, so you can't get them. But when you can get them, you don't need to buy the fancy ones. You just basically need vitamin D. Right. So that is to boost your immune system anyway, coronavirus or no coronavirus. But in the context of coronavirus, it's not going to cause any harm if we take it. Now, in the summer months, because we're exposed to the sunshine, the body is expected to absorb and synthesize the vitamin D with the help of the sunshine anyway. So that's why we're not saying you must take it in the summer months, because hopefully we've got enough sunshine. And as long as you've got about 10 to 15 minutes of sunshine a day, that of a good, decent sunshine, that should be enough to give you the vitamin D that you need. I hope I've answered that question.
Yeah, thanks. And then whilst you're on, you touched on exercise, and I think Director's question is linking it to anemia and hay fever allergies. You know, so
let me see if I can find the question. Is it on the chat screen?
Yes. So how do you improve your immune system if you are healthy, exercise regularly, but have anemia and hay fever allergies?
Right. How do you improve it if you've got allergies?
Yes, hay fever. And you
now,
are
hay fever shouldn't stop you exercising. Hay fever is just a specific kind of allergic reaction or allergic sort of condition, and it's specifically to, you know, like the pollen and things like that. It's a seasonal allergic type condition that you're dealing with hay fever. So it doesn't actually affect how your lung works. It's just that it triggers an immune response. So as long as you know what the allergen is, you're staying away from it, you're taking antihistamines if you need it, then you can still exercise. And you don't need to necessarily boost your immune system in a particular way just because you've got hay fever. What you need to do is to be able to manage your hay fever symptoms so that you don't get the distress from those symptoms. And then if you're anemic, anemia can have an impact on your immune system, not directly, but indirectly because of so many things. So when you're anemic, one, your blood count is low, so you don't have enough oxygen going around the body. And so basically that's your fuel for fueling the whole body. So you don't have enough oxygen, so you can't function properly. You get tired easily, you get short of breath, and some people become dizzy, some people even faint. So they would obviously have to be careful when they're doing vigorous exercise that they don't pass out. But every anemia has an underlying cause. And one thing which we need to know is anemia is not a diagnosis. Anemia is not a condition. Anemia is pointing to something. So if someone is anemic, don't just walk around and say, oh, I'm anemic, I've got anemia. Anemia basically means your blood count is low. Okay, low white and red cells causes tiredness and blackouts, yes. So anemia basically means that your blood count is low. And if your blood count is low, there is an underlying cause for the blood count being low. And that's what we need to identify. Is it low because of your diet? Is it low because you've got an underlying condition like leukemia? Is it low because you've got chronic kidney disease? Is it low because there is some other antibody fighting against your own body's immune system? So we would need to find what that is, sort of causing. And when you're anemic as well, your breathing can be labored. So it can affect your breathing as well, and therefore affect the amount of oxygen that's going around your body. So anemia would not stop you exercising, but it would impact on you exercising because you become more unwell with it. But more importantly, we need to find out why you're anemic so that we can get to the bottom of it. And that is what will help you know how to improve your immune system. Because if the cause of the anemia is, for instance, a chronic renal failure, like your kidneys are unhealthy, then we can tell you what to avoid to stop it making worse and what to take to make it better. If the cause of your anemia is, for instance, you're not having enough iron in your diet, then we can suggest that you take iron. If the cause of the anemia is that your folic acid is low or your B12 is low, then we can say take that to boost your immune system. So the boosting of the immune system will depend on the cause of the anemia. I hope that answers that question.
Yeah, thanks, Diana. We have another question. A gentleman says, I've been exposed to COVID. Would you recommend that I sign up for the plasma trial? I've donated plasma before because I had hepatitis antibodies.
Right, so he's been exposed. Is that a recent exposure then? Is he still self-isolating, this person?
Liza?
My partner was tested positive for COVID. We were in Cape Town
right.
maybe about 3 weeks ago. She had worse symptoms than I did. She had a headache, fever, tiredness, and loss of appetite. I didn't have the headaches, but I had the other symptoms. So she had a test. She was positive. I had the test 3 days later. My test came out negative. We both isolated in Cape Town. We came back about 2 weeks ago. We're completely, fully recovered. We're fine. Okay. I'm aware that there's a trial going on currently.
Yes.
To donate plasma. I'm familiar with the process because I donated plasma about 20 years ago.
Okay.
Hepatitis. So would you recommend that I sign up for the trial and maybe help to people who get exposed subsequently?
Yeah, I mean, it's a personal decision, isn't it? And it's obviously commendable that you'd want to do that and help. But certainly, if you feel that it's something you want to do, then yes, you can. They obviously have very strict inclusion and exclusion criteria for these trials. But the fact that you're willing to do it and the fact that you've already been exposed is in itself a starting point. So simple answer, would I recommend? Without influencing your decision, yes, I would. If you want to go ahead with it, is it something you must do? No, you mustn't do it. But if you feel that you want to do it, then that is a great thing. And when you get down to the actual recruitment process, they will then talk you through whether you're a suitable candidate or not and what needs to happen. But I think that generally anything that anybody can do to help get a solution would really be appreciated. So clearly, if people are keen to sort of help with these things, then that is a good thing.
Okay.
Does that help? Does that answer you, Liza?
It does help me. Thank you very much.
Okay, super.
Well, I'm conscious about the time, but we enjoying, Diana's, insight. There's a question, so if you don't mind, then,
No, I don't mind the time.
carry
Don't
on
worry.
a bit more. There's a
Yeah.
question about ACE inhibitors. They're said to
Yeah.
cause more severe symptoms if Black people get COVID-19. Can you shed a bit more light on that?
Right. So ACE inhibitors, it's a group of drugs that are generally, they're used for lots of things, but generally you probably be familiar with them if you've got hypertension, any of those medications ending in april, lisinopril or ramipril or enalapril, and they're the ACE inhibitors. ACEs are also used for other things like heart failure. They can also be used in diabetics who have kidney impairment, where we think that that will be the most suitable blood pressure pill for them. And they're used for lots of different things, ACE inhibitors. So when it all first started, because of the way in which the immune system is modulated when you're responding to the coronavirus, or when people sort of then have the breathing manifestations or the breathing response to the coronavirus, the ACE is called ACE's angiotensin converting enzyme. And the ACE inhibitor is basically anything that stops that enzyme from working. And that particular enzyme, ACE, modulates a pathway in our immune system. It's part of the normal immune process. So ACE is doing the job as one of the members in the army fighting against infections on a daily basis. This is something that's happening in everybody's body. As we are all sitting here, our ACEs are working, part of our immune system, modulating a certain pathway. So what the worry was that they were then saying that, oh, if we've got people who are taking this ACE inhibitor, and the way in which the ACE inhibitor works is it inhibits that particular ACE pathway for those patients who need it for that reason, which is a beneficial thing for them. People suddenly started panicking and saying there probably could be a link where if the ACE inhibitor is inhibiting that ACE pathway, then we are weakening our immune system and therefore predisposing ourselves to a worse reaction from coronavirus or more fatalities from coronavirus. That caused panic, and obviously people started saying, I'm going to stop taking my ramipril, I'm going to stop taking my lisinopril, etc. It's a similar phenomenon with the ibuprofen, the NSAIDs, where again, people started panicking because they said that the NSAIDs is dampening the body's natural immune system. And therefore, if you take ibuprofen, then you're fighting against your own soldiers, and therefore the soldiers cannot fight against the enemy coronavirus. But again, it's one of those things where these are theoretical. We haven't done the studies in large numbers. We haven't studied it. We haven't got the evidence. And so until we get to that point, we cannot say it definitely is the case. So theoretically, anything could be possible under the sun. But when you actually subject it to a real study, you then find out that because the body is not just running on an ACE pathway, and therefore if you take an ACE inhibitor, you're going to stop everything else happening. Maybe in a real world, it actually isn't the case. So as of last week, with the studies that had come out on small scales, the advice is that carry on taking your ACE inhibitors. Please don't stop taking them, because you're on them for a particular reason. And if you're on your ACE for a hypertension or a heart failure, or you're a diabetic who's on it for some renal impairment, if you stop taking it and that condition gets worse, that in itself makes you more predisposed to having severe illness and probably being very unwell, rather than the good that you intended. So please don't stop taking them. And please, there is no firm evidence confirmed as yet that ACE inhibitors would make you have a worse outcome from coronavirus. Equally, there isn't any confirmed firm evidence about ibuprofen as well. But ibuprofen is one of those tablets that you can take it if you need it, and if you don't need it, you don't have to take it. So it's not a big deal. If you don't need it, then stay away from it. But if you absolutely need to take it, then please don't stop yourself taking it. But your ACEs, they're crucial drugs, and people who are on them must remain on them, because these are the people who are already at risk for other reasons. And by stopping those medications, they're putting themselves at risk for something that is not proven. Thank you.
Okay, I have one more question, and then if there are any more questions, you can put them in the chat box. We hope to finish by 1:15. And if you agree, we'll try and get Diana back, if not next week, the following week. There's a question about why, Black people seem to be dying at a higher rate, in the hospital setting. There are some myths there about criteria for ventilation, which tends to disadvantage us because of underlying health, conditions. But I think the Institute of Physical Studies did a survey, and Black Africans 3 times higher death rates than white British. Are there, can you give your personal thoughts on that? I know we haven't done, the test and, large trials.
Yes. I mean, it is concerning, isn't it? It's really disheartening. It's very concerning that our people are dying disproportionately. Our people are getting severe illness disproportionately. Just to put it in context, if you think of the NHS workforce, we make up 44% of the NHS workforce. The BAME community makes up 44%. That's almost half. And yet the deaths that have been recorded is about 72%. So it actually makes you realize the gravity, the scale of the problem. And even if you look at the general population, it is still that we are disproportionately having adverse outcomes from this COVID-19 disease. What are the possible factors? Again, these are things that are speculated. They are things that are sort of projected as possible causes. There is a very strong push at the moment from all the medical bodies, nursing bodies, healthcare bodies, that there must be a proper inquiry into this, and as soon as possible as well, for us to find out what the actual problem is before more people die, more people are put at risk. But very briefly, I have listed a few things that are possibilities, and please don't quote me as the all or none on this, but those are the possible factors why we could be having these disproportionate deaths in the BAME community. So first of all, we as a group, as an ethnic group, have coexisting health issues. So because of our genetic makeup, because of our ethnicity, we tend to have diabetes a lot, especially the Asian community. Lots of them have diabetes, type 2 diabetes. We tend to have cardiovascular disease a lot. We tend to be hypertensive as well. We tend to have renal failure, which we are not aware of. If you're in a developed country like here, then yes, we can tend to get to know these things. But these are strong health conditions or underlying sort of illnesses which we tend to have, which already is putting us on the back foot to begin with. So that's number one. Number two, generally, we probably do have a lot of BAME people in some poor socioeconomic sort of backgrounds as well. So that doesn't help, where we are already disadvantaged from a sort of economic and health point of view. So there are these health and economic inequalities that is also working against us. And then if you think of our setting, because of the way we grew up, our culture and stuff, we tend to be more of a communal setting type people. So in the same house, you might have about 2 or 3 or 4 generations living together, grandparents, parents, children, you have cousins, aunties in and out of the house, that sort of thing. So that physical distancing thing, probably not as it would be in your standard Caucasian family, where you probably just have 2 or 3 people living in a house and, they barely see the extended family or, something like that. So again, that is another thing where it makes it easier for transmission to happen. Also, we make up quite a large chunk of the front line. And the way this disease works is based on exposure. So if you're the one who is at the front line all the time, you're more likely to come into contact with the virus. And the more you come into contact with the virus on a daily basis, high doses being exposed to you, you're more likely to get disease from the virus, and probably more severe disease. And when we live, if you look at where the BAME community lives, we tend to sort of live in the urban areas, which is densely populated, close proximity, where the contagion rates are high. So all these things are already existing conditions that have set us on a back foot. So if you take that, and as I said at the beginning, if you've already got these risk factors, plus you're at the front line, you are in contact with that very sick coronavirus patient, you're the one who's having that direct sort of impact from the virus, you're probably more likely than someone who isn't to have disease. Now, they're trying to look and see whether purely by being Black or by being Asian or being from an ethnic minority, does that in itself, is there something in our makeup that is predisposing us to getting severe disease? And I think that is what we're waiting for an answer to see whether, is it just these factors that we're already aware of that already existed, which have just become more obvious? Or is there actually something in our makeup that is making us more prone to getting these adverse outcomes? Over to you, Charles.
Yeah, thanks, Diana. I know you don't work in the acute setting, but you know, there's so much myths out there that we're not prioritized when it comes to ventilators. I know, you know, our politicians have told us that there's no government. You know, can you comment?
I would comment, but cautiously. Yes, I don't work in an ITU setting, so I wouldn't be able to say what the current exact criteria is for putting people on a ventilator. But I do know that we haven't got a shortage of ventilators at the moment. So I don't see how that would actually come into play, where purely because you're Black or you're Asian, they'll say, oh no, you're not fit or you're not good enough to go on a ventilator. And also the medical profession, is not supposed to discriminate. And we're supposed to treat all patients equally. And I know that's a debatable topic because obviously we do find inequalities wherever we are. But if a patient is unwell and they need a ventilator, we're going by what are their medical statistics, what are their vital signs at the moment, what can we achieve by putting them on a ventilator. And they're not going to go by the color of your skin or your race or anything like that. How well you do on a ventilator might be determined by the underlying conditions that you have. But I certainly haven't heard or got any evidence that purely because of being from a particular ethnic background or from a particular racial background, you will be discriminated against by not being put on a ventilator. I certainly haven't heard any of that. I haven't got any evidence of that. So I really can't say that is the case. I'll be quite appalled if that is the case, but I clearly don't have any evidence of that. And we've had patients who have survived and come back home, and we've had patients who've died. But in all the settings, remember, the BAME community make up 44% of the NHS workforce. So we are the same people at the front line. So if that sort of discrimination is going on, then actually probably we are part of the problem. I don't think that is the case, and I hope it isn't the case.
Right. So yeah, we'll be just wrapping up. But you know, some have been making an argument for GPs testing, you know, Black people as a routine for vitamin D levels. What would you say about that?
Yeah, there's always been an argument for people wanting a vitamin D test. The argument has always been that it's not cost efficient. You remember, everything we do on the NHS has some cost efficiency relation to it, not because that's the primary reason for doing things, but is one of the factors to be considered. And it's a factor to consider because whatever services we offer needs to be equitable. So we're sharing resources that should be equitable across the board. So it's a case of, if a test for vitamin D, so let me put it this way, if someone has severe vitamin D deficiency and they have symptoms, like they're tired, they tummy aches, they're really weak, they're lethargic, they can't do anything, you know, they will get tests done anyway. Most of the time when we run tests for anemia, for kidneys, for liver, if people are presenting with these tired all the time symptoms, most of the time vitamin D gets tested anyway, because we know that extreme low levels can cause those symptoms, which can mimic so many other conditions. But if someone hasn't got any symptoms wrong with them, they're just like healthy, they're going about their daily business, it's far more cost effective for them to go and get this thing I was talking about, which costs £1, and take it, rather than a test that might probably cost, you know, say £10 or whatever. So multiply that by the general population. Is it cost effective? And if we as Black people, because of the skin pigment, are absorbing less vitamin D compared to the Caucasians, there could be an argument to say that, yes, why don't you test all of us? But how often do you do these tests? Are you going to therefore be testing? Sorry, you're on this room. Are you going to be testing on a daily basis? Are you going to be testing weekly? Are you going to be testing yearly? When what we can basically say is We know that we are at risk of having lower levels. We know what we can do to get our levels up by the right diet, by the right levels of exposure to sunshine, carefully and sensibly though, and also by taking this supplement, which you can just get easily. So unless there is a medical indication for it, generalizing it becomes a bit tricky. And I think that's what the problem is. But I think we are heading into a phase where a lot of things are going to change because of what's happened with the way the BAMEs have had an outcome from the coronavirus. So watch this space. It may well be that that becomes something in the future. Liza, you had a question on there, did you? I'm trying to sort of see if I can find it. Yes, there is a case for commissioning. And as I was saying, watch the space. It's probably something that is going to come up. Remember, these are discussions that keep happening behind the scenes. And as more and more cases come up, it then generates and triggers someone to say, look, actually, why don't we implement this as a pathway? Why don't we commission this service to address this particular need? So I think it probably is in the pipeline happening at some point soon. Right.
Thank you very much, Dr. Diana Asante. We're hoping to have you probably next week or in 2 weeks' time. You know, we know you've given up some precious time, you know, and your 3 girls are waiting for you. So we're really grateful. We've recorded this. We will make sure we edit, you know, bits of that and then, you know, post it on our YouTube channel. So thanks everyone for making it on behalf of the Caribbean and African Health Network in Greater Manchester. We want to say thanks to you.
Thank you for having me. It's been a pleasure as well.
Well, this is the beginning of many to come. So, you know, watch this space. All right. So thanks everyone. You know, next week, same time, 11 o'clock, we will make a start with, you know, Doretta. We're going to have, you know, I think Hiba is joining us, but, you know, we're trying to sort out a time during the week to look into the nutrition stuff, you know, and the veg and the fruit, pick up on some of those conversations. So thanks everyone. Enjoy the rest of your weekend. Bye.
Bye. Thank you.
Bye.
Bye.